Good morning. This is Senate Health and Welfare, and it is January 27th this morning. We have a couple of things on our agenda. One, we're going to look at a committee bill very briefly, and then we'll be looking at a consultant report that was presented to the Health Reform Oversight Committee, and we'll talk about that when we get to it. And then we'll hear some information from Green Mountain Care Board and Healthcare Reform Officer for the state of Vermont. So Jen, you have prepared us a very attenuated, short committee bill that we can introduce, hopefully we can introduce today, and then have recommitted to our committee so that we can more fully develop the bill. So this is not a final bill. This is like being introduced for the first time, as any other bill is, and then the committee can change it as we go through and hear testimony. So why don't you go through the bill with us, and then we can finalize the process to get it up to the Secretary's office.
Sounds good. Do you want me to put the bill up on the screen?
I think so, just briefly. Yeah.
Great. So good morning, Jen Carby from the Office of Legislative Counsel. This is as the chair said, a draft committee bill. It's expressing intent to expand the blueprint for health and access to home and community-based services. And the idea here is to meet the committee bill introduction deadline, which is the 31st. But in order to meet that deadline, the Senate Secretary's office has indicated bills need to be to the office today. And so then you would follow a path to have it recommitted to the committee for further work. So it's just one section and an effective date. And it says that it is the intent of the General Assembly to expand the blueprint for health and access to home and community-based services. That's that moderate needs group, which were recommended in the report of the consultant to the Task Force on Affordable Accessible Healthcare established pursuant to last year's budget bill in a particular section. And it would take effect on passage. So it's sort of a placeholder bill in legislation form.
Okay, committee, questions for Jen and comments? Go ahead, Ruth. Senator Hardy, go ahead.
Thanks. Jen, if we ended up wanting to do one and not the other of these, does this intent or the name of the bill make any difference?
I don't think so. I mean, you'll be doing a strike all amendment when you take it up. So we can, if you only end up doing one, we can change the name at the end, or if you end up adding other things that make sense, we can change the title to reflect the bill.
Great, thanks.
Any other questions? Committee, so we should probably, do we do a formal vote on this?
You would need to, it's a committee bill.
Yeah, we have to. We don't have our clerk with us. Aaron, can you fill in as clerk? Let's see, Vice Chair, can you fill in as clerk, please? And I would accept a motion.
I move that we pass the bill as presented.
Okay.
Or whatever I'm supposed to say, Jen.
Would it be?
Bill.
Yes, it's draft bill number 22-0575.
Okay.
Draft 1.2.
Draft 1.2. Perfect.
Okay, shall I call the roll?
Any further discussion? Okay, then please call the roll.
I'm going to do it alphabetically.
No, you do it. What you do is.
What do I do?
You can do it alphabetically. The vice chair and the chair go last.
Oh, okay. Senator Cummings, you're muted.
I'm muted. Yes.
Senator Hooker.
Yes.
Senator Hardy, yes. Senator Lyons.
Yes.
Okay, great. Aaron, just let me know if there's something I'm supposed to do to fill out a form or something.
No. So the next step is I think based on multiple conversations And Jen, you can correct me if I'm wrong, but I believe that then Aaron can report this to the secretary's office for
Actually, what we'll do,
introduction.
because it's a committee bill, is that I need to communicate it to the drafting operations office with confirmation from the chair that this is in fact the right version and that you intend to introduce. We're trying to replicate in an electronic form the signing the first page of the bill. We do.
So do
already
you
go-
need me to send you an email on this?
I will send an email to the drafting operations team and copy you and ask you
Okay.
to confirm. And then if you
Okay.
can confirm, we should be good.
Okay. So then Aaron,
Yeah, sorry. I just have to tell the secretary's office that you voted out the bill so they know. And I also need either Senator Terenzini or whoever is acting as clerk
Senator
to
Hook Hardy.
approve the record of action when I send it to you. So I'll send that to you and you can confirm that it's correct and et cetera.
Great,
Do you
thanks.
need a reporter for this? Because I need to record that.
No, as a bill introduced, and I'll take over that job. And then when we get to the floor, after it's introduced and we have a time for announcements, I will ask for the bill to be recommitted to the Senate Health and Welfare Committee.
Okay.
Yeah,
So I'll
we're
just
good.
report, I'll just record you as the reporter because I have to put somebody.
Yeah,
So-
do that. That's good.
Okay, great.
Then, okay, Jen, so I'll look for your little email or the email and then.
Yep, I'm
this-
going to work on that right now.
Okay,
and
good.
then get to you.
Thank you. And I think this solves the problem. I will just let them know that I will not be in rules as long as we get this bill going. All right. Aaron, I think now it's time to invite let Donna Kinzer in from the waiting room, and then we can move on from there. Okay. Good morning. Good morning. Welcome. Before we begin with your testimony, I'd just like to share with the committee that you did work with, in particular, Senator Kitchell and then members of the Health Reform Oversight Committee as a consultant to bring us your report. The goal for us today is to look at your report, understand what it is, and then any potential recommendations with regard to regulatory, the regulatory system and oversight within perhaps Green Mountain Care Board or others. And so then after we've had an opportunity to hear your report, then we'll hear from Green Mountain Care Board and the Health Reform Director for the state and understand their perception of what we might do in terms of regulatory changes, if any. So that's really the goal today, and we appreciate your time and that you are here to walk through your information. So why don't we have committee members briefly introduce themselves? Senator Hardy.
Good morning. Hi, Donna. My name's Ruth Hardy. I'm the senator from Addison.
She's also vice chair of the committee.
Good to meet you.
Go ahead. You're muted, Senator. Senator
you
Cummings, you're muted.
Hi, Donna. I'm Ann Cummings, and Donna and I know each other from the other study with joint fiscal.
Okay.
Good morning, Donna. I'm Cheryl Hooker. I'm Senator from Rutland County.
All right. And we've met at Health Reform Oversight Committee. So welcome. Why don't you introduce yourself for the record? And then I know you have some testimony, and I think if you would like, we can share screen if Aaron hasn't already done that.
Okay, thank you. And my name is Donna Kinzer, and I thank you for the opportunity, Chair Lyons and committee members, to be with you here today. It's an honor to serve you. And I do want to thank the Joint Fiscal Office staff, Nolan Langwell and Stephanie Barrett, for their help in this process of bringing this report forward. And also, I would like to acknowledge and thank the stakeholders and state leaders that I interviewed for their time in moving this report forward. By way of background, I am the past executive director of the Maryland Health Services Cost Review Commission. I served as the executive director there for 6 years while we implemented the Maryland's all-payer model. And beyond that, I have a 40-plus year career working in the healthcare field, a lot of it focused on payment and delivery system modifications. So that's briefly by way of background. And I am going to, Chair Lyons, share the screen. I will try to work efficiently through the presentation. I'll be skipping some of the materials so that we can move through that and get to discussion. Please feel free to stop me and slow me down or speed me up as we work through the process. So I am going to go ahead and share my screen.
And as you're doing that, I think we're very used to the process of asking questions of clarification. We try not to get too deep into the conversation, but sometimes that's unavoidable. But we'll try to keep moving along so we're timely.
And as Chair Lyons mentioned, this is the report that was prepared for the Health Reform Oversight Committee. And just briefly, I know that you have the report. We're not going to go through all of it today, but the table of contents shows what is included in the report. And just to begin touching on the objectives of the study in the report, I had met with the Health Reform Oversight Committee back in the fall, and the discussion centered around how would you go about evaluating changes that are needed to the regulatory system. And the suggestion was to use an information-driven approach to the process. So the focus of my work was to look at the data and information that is available for you to utilize in understanding healthcare cost and cost growth and opportunities to reduce cost. And then secondly, to obtain qualitative perceptions regarding the system performance and potential performance gaps from interviews. And just to dive into that a little bit more, the process that I used to conduct this assessment was to review and evaluate the information that's available on healthcare cost. That involved reviewing dozens of reports and talking to state staff, looking at data systems. The second pillar is the interview process, and I interviewed approximately 45 individuals of stakeholders and state representatives in the process, and then to summarize and synthesize the results of this review process. And I know that you're fully aware of this, the situation of COVID-19 and its impact on the healthcare system, but I would be remiss in just saying that in terms of evaluating model results and potential regulatory changes, the impact of COVID-19 is very significant in terms of affecting the pace of what you might do But also as we start looking at data from 20 and 21, it will cause distortions in the data that you will have to review. So I'm going to start first and talk about the cost information that is available to you to assess the level of cost, the cost growth, and then also comparative information. So that is the first area of inquiry that we talked about. And I am happy to report to you that you have very strong data sources to evaluate cost and cost growth. You have the Vermont Healthcare Expenditure Analysis, which has a comprehensive collection of healthcare costs, both from patient bills and claims data, but also all of the expenditures that are also coming from other sources, such as the state expenditures for long-term services and supports that are more grant-based, and some of the behavioral health funding, et cetera. But the healthcare expenditure analysis is comprehensive. And then the second data set that you have is the VCURES, or the Healthcare Uniform Reporting Evaluation System, which is your all-payer claims database. That data is has more granular data and can be utilized to get to a deeper level of understanding of cost information when that is needed to really drive an understanding of cost and cost opportunities. So these are two data sets that are maintained by the Green Mountain Care Board. They're well documented. The gaps in these data are well understood. So these are excellent data sources for you to utilize. And I'm going to skip talking about them in more detail here. And I'm going to go to what I found in terms of the gap. So you have good data to understand cost, but what we really don't have is comparison data. So we don't have good data to compare to spending levels outside of Vermont. And what we do have is extremely high level, so it lacks sufficient detail to really understand the data. So we're looking in terms of trying to put a stake into the ground. If we're trying to develop policy, we'd like to know if we're high cost or medium cost or low cost, or where are our opportunities. And that data, we really don't have a good data set to look at. So, and there is some data from the National Health Expenditure accounts, but they're very high level and they're not trusted because of all of the border crossing that goes on between New Hampshire and Vermont and New York. So, the recommendation, the first recommendation from this evaluation process is that the Green Mountain Care Board should consider engaging a third party to do a per capita benchmarking analysis, hopefully at the state level, but also at a local level, so that it can be utilized to look at opportunities for improvement, but also put a stake in the ground in terms of where are we performing. So looking at national data, peer data, and better performers in terms of that benchmarking. And there is a second suggestion going along with this first benchmarking suggestion, which is while we're having a consultant get into the claims data to do this benchmarking analysis, a number of states have also performed analysis of low value care. And that is defined as care that can provide little or no benefit, could cause harm, and is potentially wasteful. Now, of course, the ultimate decision of these things is back in the doctor's hand, but this is an analysis that can help provide some indication of opportunities to potentially eliminate low value care and then hopefully free up that money for investment in other things. So the second recommendation is to consider adding an analysis of low value care to the benchmarking process because it will be cost effective to do them at the same time.
Can I, let me ask a question here, please, about low value care, and that frequently, maybe not frequently, but we see that some of this care is linked to defensive medicine. Was there any discussion about that from folks as you were carrying out your interviews?
That topic does come up from time to time, but with these new reports, nationally, the physician community has gotten behind these reports, and these new reports are coming out of the quality agencies in the physician community. Johns Hopkins just published a report last week, so there's more physician buy-in to these newer approaches, and that does help to set the community standard of care. So there's always concerns with malpractice, but these newer definitions are better and vetted with the medical community.
All right, thank you. That's helpful. So it goes more toward quality and cost of care rather than what we've seen in the past.
Right.
Yeah,
So it's
okay.
yes. And Senator Hooker, did you have a question?
I was just going to ask for an example of low quality care. And I mean, this is new to me, and I'm just looking for some kind of guidelines as to what these terms mean.
So low value. So
Low value.
here's an example. You have a perfectly healthy 30-year-old who's going in for an ambulatory surgery, and they've had a medical examination. They have no problems. They don't have bad blood pressure. They have no medical problems, no medical history. But we give them an EKG and we do all of this other stuff to work them up. And so the medical community said, we don't need to give them an EKG. That's a waste of money. They should be able to get a simple surgery without an EKG. So that's an example of a waste in terms of low value care. And there are certain instances where people get radiology procedures, and then you're getting exposure to radiation every time you get radiology procedures. So if it's unnecessary, then that is potentially harmful if you follow that logic. Does that explain things?
That's helpful. Thank you.
Thank you. The second recommendation is when I went to review the reports from the Green Mountain Care Board, they had dozens of reports, very interesting and well done, hundreds of pages, but that's going to be a little difficult for the legislature to absorb hundreds of pages of reports. So the suggestion here is that they should be summarized, synthesized, and the key findings and recommendations ought to be brought forward from those reports for the legislature.
That would be refreshing.
Yeah, so that's I always think it's good to spend one or two or three people's time summarizing instead of 40 people trying to read something and understand it.
And
Um,
skipping over and misinterpreting and it's,
Yes.
but yeah, okay, thank you.
Mhm. So the next area that we're going to look at is just some of the data that's available from your the BHCEA reports, the healthcare expenditure reports, and look at them in an overall context. So this is a picture of your healthcare expenditures from 2019. And so you can see at the top, that's $6.5 billion. The green section at the right-hand side of the report shows the amount of the expenditures that were under the all-payer accountable care total cost of care model. So that's just over $3 billion. So you can see about half of the expenditures. And importantly, and we're going to get to a recommendation very soon on this, you'll see that out of the expenditures that were under the all-payer model, only about a third of them got into the ACO model. So that leaves about 2/3 of them outside of the ACO model. And what we'll talk about in a few minutes from now is what the concern with that is that part of the ACO model was intended to get providers off of the fee-for-service system. But what we see here is that the providers are still, because there's so much of their revenue that's not under the ACO model, the providers are still heavily linked to the fee-for-service system. And that is going to work against the effectiveness of the all-payer model. On the left-hand side of this chart, what we see is that we have government healthcare activities is one of the big buckets here, and that is mostly Medicaid expenditures for things that are under your review through the budgetary process. But we also have a big area of drugs, primarily drugs, of about $1 billion. And these are not under the all-payer total cost of care model. And they are one of the fastest growing costs. So out of this review of these broad expenditure categories, the next recommendation relates to drug cost. And as you consider changes to the evolution to the system of continuing to try to evolve strategies to reduce the drug expenditure growth, which is among the highest of cost increases. And as you can see, a very large category of expenses that is not under regulatory processes. So the recommendation, yes, Senator.
No, go finish your recommendation. Apologize. Go ahead.
So the recommendation is really to consider additional cost containment strategies. And I've noted that NASHB is one source of information for states regarding these strategies. And secondly, your ACO and physician providers can take a larger role in selecting cost-effective, high-quality drugs. It's not just about generics and brands, it's also about selecting out of a list of available alternatives, those that are more cost effective. So as an example, my husband was prescribed a drug for high blood pressure that is So the doctor said, great, we've got a new drug for you, $400 a month. He didn't say that. That's what my husband found out at the pharmacy. He works in the healthcare industry. He consulted a pharmacist and went back to his doctor and got 3 drugs instead of 1 for roughly $10 a month. So these are equal. These had equal efficacy, but not equal cost. And so these are things that doctors and ACOs can help in terms of keeping costs down. But I realize that this is a very complex area, and that the federal government also has to play a role ultimately in cost containment. Now, Senator Lyons, were you wanting to make a comment or ask a question?
I have a question, and then I might, and then I have 2. So it's also the transparency of costs between the provider and the pharmacist. So having had a similar experience in my family where a drug was prescribed and going to the pharmacist and finding out that the cost was $1,500 for 1 month, and then finding out that a pharmacy would provide the same drug for $300 a month, that was an eye opener. The physician had no clue of the cost. So somehow there's lack of communication about drug costs. And I think you've reinforced that at the provider level. So Senator Cummings is going to have a question, then I'll go back to my other question.
It's just
Go
a
ahead.
comment. When we worked a lot with Maine and the legislative, whatever we called ourselves on drug pricing,
Yep.
we set up a counter detailing when we banned
Yep.
free lunches to doctors. I have a feeling that's fallen by the wayside, but it was exactly to do this thing. The purple pill, the new and improved purple pill, which costs 3 times as much, only has a time release in it. And you can take 2 of the old purple pills for half the price. And I think that's fallen. But
let's
did
find
work
out
on
where
this.
that is. Let's find
Yeah.
out where that is.
we did
Okay.
work on that.
Yeah. And we also did work very closely with NASHB. I presented at their annual meeting a couple of years ago on our Canadian importation bill. But that's a federal, again, that's what you have indicated as a federal issue, and moving those rules forward to allow for importation.
Yes, and I think some of the federal negotiation rules, of price negotiation rules are some of the other examples of things that the federal government may need to help move forward. But I do say that some of the best ACOs are working on these drug acquisitions with the physicians. And they've developed, they pick 5 or 10 high priority drug categories to work on, and they provide the physicians with information that helps them quickly get to the right selections. So there is work being done that's successful.
That was actually my second question, and that relates to how the quality data that is being collected at the ACO level is informing some of the prescription drug decisions, clinical decisions.
Right now, the ACO is not focused on drugs, so that would be a future focus. It is not part of the ACO agreement today. So that's why I was showing you the chart where the drugs are not under the APM. And I don't suggest that you ask your physicians to take risk and your ACOs to take risk for the cost of those drugs, but there are other models of incentives where they could work together to maybe share some savings.
Okay.
The next area, so we're going from data now into recommendations that came from the stakeholder interview process. And we're starting with looking at the ACO APM strategy. And generally, the strategy and concept is supported because it builds on the blueprint for health and the primary care relationship. It builds on the high vertical integration, which means the hospital ownership of physicians' practices in the state. But there are some needed enhancements. And so we're going to talk about that. And also, there are some gaps in performance. And I will say, as there was general support, there were also alternative views. And some folks said, does the ACO add much beyond the blueprint? But the ACO strategy is a strategy was set forth to get providers away from fee-for-service, which hasn't fully worked, as we discussed a few minutes ago. It also is to focus the providers on the total cost of care, which is the strategy that CMS is moving forward with. Now I want to just step into the recommendations that came out in terms of the performance of the regulatory system relative to the ACO model. Much of the regulatory structure that you have in place was put in place before the ACO APM model, and it's kind of layered in terms of the structure that's in place. So what I heard during the interview process is that as we continue to develop the all-payer model, that we need to look for opportunities to align the regulatory systems, and in particular, changes to the hospital budget review process, which I'll get to in more depth in the next slide, as well as streamlining in other review processes in alignment with the new model. And I really want to focus on the next recommendation because I think this is probably one of the highest priority considerations in terms of making the model meet the initial objectives of moving away from reliance on fee-for-service. So as we looked at on the several slides ago with that color chart, less than half of the hospital payments are under the ACO purview. The majority of the hospital and their employed physician cost is really still being driven by fee-for-service incentives. And that is potentially working against you in terms of making the model perform in terms of cost savings. The review process for the hospital budget is not clearly aligned with the ACO model, and many of the interviewees as well as the consultants' reports did raise this concern. So the recommendation that is here is to consider moving the hospital budget, the hospital review process away from the current approach and to move to a fixed global payment option. And under a fixed global payment option, the hospitals and their employed physicians could be on a fixed total payment for their whole hospital, not just the members that were attributed to the ACO. So then we would be able to get a large sector of the all-payer model off of the fee-for-service system. And just as an example of why that's important, on page 35 of the report, and I don't want to make you dizzy by flipping back to it, I can if that, but what you would see is that the outpatient services are driving most of the hospital profitability in the state. And some of those services really don't need to be done in a hospital, and they could be done in the doctor's office, but the hospitals are having to hang on to those services in order to balance their budgets. So in order to really get a correction to that part of the system, the global payment option would help relieve that particular problem, for example. Senator Lyons.
So as you're going through this, you're talking about expanding the all-payer model, but without also at the same time putting hospitals under the ACO umbrella. So it's the implication there that the all-payer model could be instituted separately from any ACO. That's a question, but then as a sub-question to that, what are the implications for collecting the VQRs and other data or doing quality analysis?
So the system could be run in tandem with the ACO model. So basically we would have the hospitals and the physicians, but the entire hospital and the physician on a global payment option. And the part that was under the ACO would be aligned with the ACO budget. We have to have some primary care focus and focus on total cost of care. So we need to have the ACO or some other structure that operates like the ACO. For example, Maryland has a global payment model and a primary care physician program, and they operate together. So in your case, you already have the ACO started, so you could continue with that and operate it together with the global hospital and our health system payment model. So they would operate together. In terms of quality data and data in general, your ACO is collecting data for only about 1/3 of the expenditures. So you need to collect data for all of the expenditures if you're broadening the system to include, the other 2/3 that isn't getting in under the ACO model. And I think there are some issues as further along in the report about the data collection and dissemination now of needing to make sure that in terms of getting transformation has to happen at the local level. It has to happen in the physician's office, and we have to get the data into the local health systems and into the local physician practices to transform the care and evaluate and reduce avoidable costs. So it does have data implications, Senator Lyons, in terms of data collection.
Thank you. Okay.
So I'm going to move on from this recommendation, but again, just state that in terms of getting to the original objectives of getting further detached from the fee-for-service system, this is a high priority recommendation from the stakeholder interviews and from my work. The next section of the report gets into the ACO and all-payer model implementation and looks at some particular concerns that were raised during the process. And the first area relates to affordability. There is an affordability target that was a growth target that was put into place, but in the interview process, I think the consumers are focused on really trying to tie that more closely back to consumers and the impact of affordability on consumers. As healthcare spending grows, that impacts wages and it impacts expenditures for other services. In terms of and the growth targets that were set in place were done some time ago. So the sixth recommendation really is focused on could Vermont benefit from developing growth expenditure targets and defining them in a context, and also pulling in things like drugs into the affordability targets, which now are not part of your growth targets. Some of the examples mentioned of these targets are Rhode Island or Massachusetts. I will point out that you have to have tools under targets. A target by itself really doesn't ensure success. You can still exceed the target even if you have a target in place. And
the definition of affordability becomes important. I think that part of the work of the task force that completed its work also recently is a definition of affordability. So, and I think our committee has looked at those, but we may, I don't know, recommendation number 6 is something that the committee hasn't landed on recently with the other report, but we'll see what thoughts are going forward. And I'm going to skip a few pages where we talk about the ACO and some of its accomplishments, and I want to focus on the concerns because those are where we lead to recommendations. And this gets back to Senator Lyons about some of the concerns about data and resources, getting down to the local level and into the practices that is needed for transformation. And to put that in context, the best in class payers in the country will deliver digested data to the ACO, and the ACO just has to take that data and work with the communities and stakeholders. Your data is raw, so your ACO has a lot of work to do to get it usable for the stakeholders. But I did hear in the interview process that data and transformation model isn't fully developed at the local level. The data isn't getting uniformly from the ACO into the practices and into the local communities. And that there's limited sharing of best practices across the provider setting. So this is a significant concern because it limits the effectiveness of the ACO. Well, it also, by saying that, it limits both clinical outcomes and then also resulting any cost savings that would come from improved clinical outcomes.
Yes.
Yeah,
And then
so,
also the providers don't know what to focus on because they're not being given enough data at the local level. So that transformation model isn't uniform, and it hasn't been implemented at a local and practice level to the extent that is necessary for success. So the recommendation here then says that to continue to escalate and consider the strategies and the transformation model to get that data to a process that to the level that it needs to be, and then also to deliver it effectively with transformation resources, and that's human beings helping doctors and helping their systems with actionable data. It's also using the computer systems that you've invested in to provide workflow tools to the providers to help them with this. And it's bringing together that cost and quality data, Senator Lyons, that you referenced, so that the doctors know which patients have gaps in care. And that means like they haven't had their preventive work that they need, or their blood pressure is not under control, or their A1C, their diabetes A1C blood level is not under control. So this is an important recommendation in terms of making the model work.
so on at a more discrete level, the implication here is some additional investment in how to coordinate the use of the data that may be available in the health information exchange. So outside of the ACO, I mean, it could be inside the ACO, and we've heard the struggles that are going on there with putting the data together. But what, from your perspective, would have to happen for the health information exchange data to be utilized by, let's say, a group of primary care providers? Because I know they're working so hard on this, but we don't want to see the hamster on the treadmill.
Yes. So, you also don't want to let the perfect get in the way of the good. So you don't necessarily want to walk away from what you're doing with the ACO, because they have done a lot of work with the data. And so there's transformation resources that could be put in place. But in terms of getting to that broader data set, because we looked at the fact that only about a third of the data is now flowing through the ACO. I can't answer your question, Senator Lyons, because I really haven't worked with your HIE data. So I would be remiss if I tried to say exactly what would have to happen with your HIE to get it to a point where it could deliver what's needed for transformation.
Okay, thank you. Yeah, I got it.
I would just say one thing, that the electronic health record data on some of the health data needs to flow in with the claims data and back to the providers. So that'll be something to pay attention to.
Okay. And
the last recommendation relates to the control and affiliation of OneCare, the ACO, the statewide ACO. And there was a fair amount of conversation about this that came up. There have been a number of changes already to the ACO governance structure, and it is not controlled by the University of Vermont Medical Center. They have 4 seats on the board. I think at the end of the process, if you actually work on some of the other issues in terms of getting the transformation data into the local community and potentially working on the global payment model at a local community, some of the concerns that are raised about affiliation and control would go away, because that would put more of the implementation structure in the local community, or the transformation structure in the local community. But the recommendation is to evaluate whether the authority and processes are sufficient in light of the relationship with the University of Vermont Medical Center. But again, I believe that some of the other recommendations, if implemented, would alleviate a lot of the concerns relative to this recommendation. So that gets us to the end. And
Would you mind going back and going through recommendation 8 one more time, please? Just going through the Green Mountain Care Board, beginning with that recommendation, just talking through that one more time.
yes, so the Green Mountain Care Board already has quite a bit of authority over the ACO processes, and the recommendation here is to evaluate whether the authority and processes that they're deploying are sufficient to alleviate the concerns. For example, there could potentially be, and I haven't studied all of the things that are done, there could be some simple things that maybe could be added on to the regulatory structure that would alleviate some concerns. For example, if there were consumer complaints, they could be handled in the same way as consumer complaints with insurance companies. So that's an example of something that really wouldn't require an expansion of resources. The OneCare does have a consumer committee, but there could be some other simple regulatory tweaks, if you will, that could alleviate some of those types of concerns. So that's really the recommendation.
Thank you. Committee questions at this point, since we're going to go to a summary? Okay.
So I think that I've pulled together the 8 recommendations here, and I scored them. You may score them differently in terms of which recommendations I think have the highest opportunity to improve value and lower cost in the system. And the first one is to get those benchmarks. That's the 1A, and get the benchmarks and the potentially avoidable utilization as one of the higher scoring. The second is to summarize the Green Mountain Care Board, to summarize their reports. The third, also in the green, is to focus on additional cost containment strategies for drug spending. The fourth, to begin to align the different regulatory structures more closely with the all-payer model, within the all-payer model. The fifth, again, what I consider to be a very important recommendation is to consider a fixed global payment option for hospitals and their employed physicians to get away from that fee-for-service construct. The sixth is to develop the health expenditure targets. The seventh is to, and again, a green mark here on number 7, to escalate the data model options and strategies to get transformation and cost containment information to the local providers. And then number 8 relates to the Green Mountain Care Board authority and the ACO relationship and structure, governance structure. So those are the 8 recommendations. And did you want to, were you going to discuss them at this point in time, or?
Why don't we take the screen share down, and then
Okay.
we actually have the slides that you put up on our iPads. And so there's a lot here to digest in a very short period of time, if for folks who haven't, spent a lot of time looking at this. So I would open it up, committee, for questions. And if why don't we stick with the recommendations that are here? But I know that Donna is happy to go through any of the data, the information that you have in front of you. So Senator Hardy.
Thank you, Madam Chair. Thank you, Donna, for your work on this. I'm wondering, well, first of all, your full report, there's a longer report. Is that correct or not?
This is the full report. It
is. Okay.
It's 40 pages, yes.
So maybe in the appendices, do you have a list of the stakeholders who you interviewed for this process?
No, I didn't list them in the report.
Could you just generally tell me who they are?
Yes. So generally, the stakeholders are the stakeholders and state leaders are there were about 19 people from the state that were involved in the process. 8 people from hospitals and health systems or their representatives. Other providers, about 3 folks, 5 from the payer community, and 8 from purchasers, consumers, and others. So that's kind of a list of the categories of stakeholders and state leaders.
Did you speak with, I really hate the term consumers, but did you speak with consumers directly, or consumer groups, or the patient advocate for the state?
Yes, I did.
Okay. A couple of your recommendations I just am a little confused about. Recommendation number 5 and number 7, which are 2 that you thought were particularly important. Could you give me examples of how that would work in the real world? For lack of a better term, I'm trying to wrap my head around how the fixed global payments would work for non-ACO participants, and how do you bring those in if they're not already part of the ACO? And then the sort of language of escalating the process down to what I think you mean is having information right at the fingertips of doctors when they're sitting in a room with a patient trying to figure out what to do. They would have data in front of them. Is that what you mean, or is it something else? So those 2 I just would love some clarification on.
Okay, so on the first one regarding the global payment, an example of a global payment would be what has been done in Pennsylvania, for example, with the rural hospitals in Pennsylvania. Maryland also has a global payment, but I'm going to talk about the Pennsylvania model because that may be the easiest to implement in Vermont. So if we have let's take Medicare, a global budget for the Medicare patients would be set at the beginning of the year, and Medicare would pay 1/12 of that a month, or they would pay even once every 2 weeks, 1/24 of that every 2 weeks, some regular cash flow mechanism. And then underneath that, there are still claims being submitted because you still have to have coinsurance and copay, and you have to have all the information about what's going on in the system. So that's, nuts and bolts at a practical level, how that would happen in terms of a global budget. And so that would be based on the hospital's historic net revenue, or their revenue from Medicare, and the utilization, historic utilization patterns. And so that global budget would be set, and then it could be inflated going forward, adjusted for enrollment or population changes. But those are some very specific examples. I don't know if that starts to resonate or make sense, but there is a practical way that's been implemented in Pennsylvania. In Maryland, the global budget rides on top of rates that are set by the commission. So if the volumes go down, the rates are raised. If the volumes go up, the rates are lowered to stay on the global budget or the global payment that's been set. So that there are several methods that could be utilized to implement that at a practical level.
Can I insert a question here, Senator Hardy and Donna? Is it? I'd just like to, while we were going through this. So first of all, I did talk with someone from Rhode Island, and I also talked with folks about the range that you're talking about. But my question is, as we're looking at establishing any global budget or standard, putting some rate increases in place to hold things down, what, if anything, has put in place to ensure that savings go to the patient?
So there are different tactics to do that, and I think you will want to develop your tactics for that. You may want the savings to go to the patients, or you may want them to be put into the mental health system or into some other part of the system. So I think the plan needs to be developed at the state and local level about how to redeploy the savings. Some of the savings, if you will, from volume reductions, have to pay for fixed cost of the health system so they can continue to operate, because you want that to happen. But the part that is variable is something that needs to be agreed on with the state and local constituencies.
Okay. So,
And the second question related to the data, there is data that doctors want delivered at the point of care, but also I'm talking also about data to, and I was actually speaking yesterday with a doctor who's on the board of the American Medical Association, a primary care doctor, and she was talking about what she was getting from her ACO data and what she liked. So they review the results of their performance together with a group of 10 doctors in this particular ACO, and they look at what their referral patterns and their cost levels and their avoidable cost and their gaps in care, meaning how well are they doing to get their patients to have their preventive care? How well are they controlling blood pressure? How well are they controlling hypertension? And this data is brought into the practices, and they're pointed in the direction of what they need to work on. And so that is part of what I'm talking about, is bringing the data into the practices to say, here's your top opportunities to reduce avoidable use. Your patients are going to the emergency room because you're not seeing them on Saturdays and Sundays, and you're not getting them referred into the right system, or you're not using telemedicine, et cetera, and so forth. And so this is part of the data for transformation. There is some of that data could be delivered at the point of care. The best electronic health records do deliver data at the point of care into the office to say, Mrs. Jones hasn't had her preventive services. Mrs. Jones has high blood pressure and needs constant attention to that, et cetera, and so forth and so on. So it's a little bit of both, but a lot of it is really synthesizing the data to see what needs to be worked on that will help improve care and lower cost.
Okay.
Is that making, does that?
Yeah, that
resonate?
makes more sense than the previous one in terms of my understanding of it. So your final recommendations, the recommendation 8 about the structure of the ACO itself. I mean, we hear pretty constantly complaints about the ACO, distrust in the ACO, excessive administrative costs, and really just not a lot of confidence in the ACO. And we're hearing from our constituents and from people and stakeholders around the state about that. And one of the questions that continues to come up is, we have all these other structures and bodies. Why do we also need a separate ACO? And is there another model that could be used? We have the Green Mountain Care Board, we have DIVA, and we have the providers and the payers. Could the ACO just be why do we need the separate ACO? Couldn't it be part of DIVA or part of the state government instead of having a separate, what used to be for-profit now is nonprofit, but that is associated at least in name, if not more in business practice, with the largest healthcare provider in the state. And so there's just so much distrust in that. And I think that your recommendations would certainly move in the right direction, but I don't think they would get rid of all of the distrust that's been built up around the ACO. So I'm wondering if you considered a more wholesale different structure, because I think that it's preventing people from trusting the all-payer model and the system as a whole.
So I think if you actually think about the global payment approach for the health systems, if you implement that sort of a structure, it really starts to cover, as much as 2/3 of the cost, some well over half, close to 2/3 of the cost that is under the all-payer model. And it brings the control of that into state entities so that it's not so much under the control of the ACO entity. So it has to be aligned, but it really brings it more to the state control in the process. So it balances out some of the concern, I think, with the ACO. In terms of the ACO, the concept was really to get providers to take responsibility for the total cost of care and to drive that responsibility into the provider community. If you put that squarely back into the government, it actually then isn't putting the responsibility in the provider community. So that's really the disconnect of just saying, okay, well, let's just put this back into the government. The government is putting it, the Medicaid program is putting it there because they want to fix the budget with the providers. And so that's if you bring it back in, it doesn't get that job done. So I think the global payment model helps to alleviate that concern in my point of view. There are if you've got a global payment model in place and you still were dissatisfied with the ACO model, you could develop a side-by-side primary care model that starts with your blueprint. The federal government has some primary care models it's developed that would run side by side with your hospital model, your hospital health system global model. So I think if you had the global model in place, it would give you future options of what to do with the ACO and primary care initiatives. So I think this is like an evolution of, let's try to fix this problem where we're not knocking out fee-for-service incentives. And if we fix this, then we'll have some other options about how we deal with total cost of care, because we've fixed a big problem with the getting away from the fee-for-service. So I think the recommendation will give you longer term transition options than what you have today.
So that's recommendation number 5.
Yes.
That's, if you were to say, start with something, that would be the one you would say to start with. And then that would free up flexibility in some of the other areas. Is that what I'm hearing?
Yes, it would give you a lot more ways to transition if you continue to have problems. So number 5 gives you a lot more flexibility in how your model evolves. And it tackles that fee-for-service linkage directly. I also would really like to make sure that you focus on 1, which is to get some benchmarks to help see where there's some performance gaps. But, if I were scoring 1 and 5 are definitely right up there, but we have to have the data getting to the practices. So really, I've got 3 that are, kind of the top priority. We got to get the data and the transformation resources local. That'll happen more with 5 than it is with the ACO model right now. So 5 and the local data transformation, those go together. And I'd love to see those benchmarks to head you off in the right direction of cost savings.
Okay, thank you.
Does that help at all?
Yeah, no, that definitely helps. And the analysis of the low quality care definitely resonates with me. I think we all have stories about that. We could probably all just spend an hour or so sharing stories about different low quality care or unnecessary care, things that we or our family or friends have had happen to them. And so I think we all know that that's there. And it's a question of how do you get that data and talk about it without judgment, if you know what I mean.
Yeah, it's data. You're right, Senator, and it's data transformation. So making it more about the population that's being treated rather than the individual provider or patient.
Yeah. That's what this AMA board member was saying was so powerful with her ACO, was they were sitting down with 10 doctors and going through it. And then that way the doctors could talk to each other. And it wasn't just about, it was about doctors talking to doctors about how they're doing things.
And interestingly enough, I know that there's a coalition of primary care docs in our state who meet on a regular basis. It might be helpful to bring them in and ask them what they're doing in this area. Yeah. Okay. Any other questions at this point? So your highest priorities that you have listed are numbers. What? I have them written down.
5 is my number 1.
5 is number 1. I think that resonates with me.
And I just think we'd like to have that benchmark data. So that's number 1. And then number 7 of figuring out the data model to make sure that this actually works on the ground.
Yeah. That wouldn't do us any good to do something that doesn't work on the ground.
Right.
Yeah. Okay. All right. Any other questions? Senator Hooker.
Thank you. With regard to the global budget, I think one of the fears is that sort of suggests that we might move away from like higher tech stuff. Would a global budget cover the cost of those higher tech, imaging, um, that technology, that type of stuff, so that the patient didn't have to pay, the cost wasn't coming directly from the patient. Would that be covered in a global budget? Keeping up with state of the art. I think one of the fears is that, we wouldn't have the quality of care that science is giving us as we go along. So is it covered under a global budget?
Yes, and you will want to put in systems to make sure that it's continued to be available. For example, in Maryland, we had a system to make sure that the special drugs that are the new special drugs that are delivering effective cancer care and other care, that they were getting paid for in the system. So we had a special adjustment to make sure that they got the attention they deserved. So those kinds of things do have to get attention to make sure that that they continue to be dealt with. The academic medical centers had a special adjustment to make sure they had the quaternary capability if there was something new coming along. So yes, there's got to be attention to that, and it's part of the global budget process.
Thank you.
And then as you're talking, this is a very discrete issue, but as you're talking through some of this, and we know that prescription drugs are such a big increase that we're seeing in costs. And I keep getting messages from people about prior authorization for, in particular, for specialty drugs, where these prescriptions are become unavailable over a weekend when a provider is not accessible. So there are a lot of little things within this that keep things flowing. Just a comment. I don't know why it came to mind, but it did as you were talking. Any other questions, committee, or comments? Senator Cummings, okay. The issues that the recommendations that you're bringing up obviously are going to involve both public and private payers. And so having limits or standards in place, if we were looking at global payments, what is your experience with the effect of those global budgets, global payments on private payers, and how do we keep the patient in mind when we're talking about some of this?
Well, I think they can be effective with private payers. I've looked at the data in Maryland, for example, and what I see is that the private payers have gotten some of that low intensity outpatient services out of the hospital into a community setting where it is frankly half of the cost, sometimes lower. And so that's happened with the global model. So when I'm looking at a waste, and one of the thing is waste is doing something, and this isn't true in all communities because it's different where you have really small hospitals. It's not always cost effective to move. You're not going to save money by moving MRIs into the community in a small community. The MRI has to be in the emergency room. But I see that has really made a difference for the commercial patients.
Thank you. Okay. Yes, there's a lot here. It's never ending. Every time you speak, we think of other things, but and I know some of our hospitals, even pre-pandemic, were having difficult financial times, and now we're trying to keep them afloat, and at the same time trying to figure out how to contain costs. It's an interesting paradox. Well,
it is.
Yeah. Senator Hardy, please go right ahead.
Thank you, Madam Chair. So, and just scanning through these, some of these, it seems like can be done without legislation, that it's just, you know, I mean, particularly asking the Green Mountain Care Board to summarize their reports. You know, I'll just,
Oh, yeah, we would
can
would
ask
hope they
Kevin
would do
right
that.
now. But there's, you know, what are things that need legislative action, and rather than just a little push, if you know what I mean.
Do you want to answer that, or do you want me to answer that?
I'm wondering what, you know, there are some things that could be done within our regulatory process right now by our regulators, and some things that are just, I don't know. So to move to global payments, what does I would assume that's one that would have to take legislative action.
Some of these things are very large and some of them are small, but even if the Green Mountain Care Board has the authority to do something, they may not have to do it until you know, we ask them to. So providing that, yeah,
Yeah,
go,
sorry.
go ahead.
I'd
No,
like
go
to hear
ahead.
what Donna's
Go ahead.
answer is. Thank you.
Yeah, nope, go ahead.
On number one, I think they'll need funding for the benchmarking. So I think that you all would need to provide funding for them to do the benchmarking study, the Green Mountain Care Board. On the global budget process, I think they would probably want to have not the Green Mountain Care Board, but really the regulatory system, not just the Green Mountain Care Board, but the Office of Health Reform may want, and you'll hear from them next, but they may want to have legislation to focus on the study of whether that is a good option. And then ultimately, if they wanted to move forward with that option, there would likely need to be legislation to implement it. So that in terms of the data model, that some of that could certainly move forward without legislation. There will be legislation necessary, maybe in terms of some of the collection of quality data and linking that with the claims data. So there may be some legislation that you would need there, but and there also may be funding. And actually, I would say there's probably funding with the study of the global model. So there are funding required for that. I think you would best hear from the staff about funding for the HIE and whether that would require additional funding. But I think the funding mechanisms for the HIE would be a question, and then funding for the study to determine whether to move to global payments and the funding for the benchmarking study. So those are probably things that the legislature would need to get involved in. Does that answer your question?
Yes, absolutely. Thank you.
Any other questions? Okay. Donna, can't thank you enough. This has been very helpful, I think, and it's our first look at the report as we go through recommendations and begin perhaps to incorporate some of this legislatively. We may look for your expertise again.
Well, thank you. And certainly if you have further questions, feel free to reach out. Nolan Langlois is regularly in contact with me. And so if you need something, please don't hesitate to reach out. And thank you very much for the opportunity to serve you.
Thank you. And Senator Cummings, you have a question? And you're muted, Senator.
Why won't it unmute? There it goes. I just want to say, well, we're thanking Donna. I believe she is in New Mexico and it is 2 hours earlier there.
Ooh.
So as much as some of us hate early meetings. It is. And it was snowing last time we had a
Yes,
meeting
and
with her.
it snowed this week too, so, yes.
It
so-
snowed again.
Yes.
Yeah.
so-
Don't think of New Mexico as snowing.
Wait,
It
wait,
does.
wait. Just a short comment to make you feel a little bit better. It was -10 this morning outside my house.
Well, you're colder than we are.
Yes.
So I think we were down to about 15 last night, but
Wow.
not -10.
Yeah, no, we hit -15 this weekend.
Yeah. Okay, and
Beautiful.
you're welcome to stay on with us as we hear from the Green Mountain Care Board and the State Healthcare Reform Director. So, but
Thank you.
appreciate your time very much.
Thank you so much.
Committee, that I think is very helpful, and we will go back through those recommendations there are a couple bills that we have in committee that we may want to also consider while we're looking at these recommendations, and we'll bring those up another time. But now we have the chair of the Green Mountain Care Board, Chair Mullen, is here. Welcome. And we look forward to your testimony as well.
Thank you, Chair Lyons and members of the committee. For the record, Kevin Mullen, Chair of the Green Mountain Care Board. And let me start by saying that I think the legislature made a very wise choice in picking the consultant that you just heard from. We don't disagree with the findings that Donna has presented to you. And in fact, there's pretty broad agreement between us and the findings. And maybe I should start out before I walk through the 8 different recommendations, but maybe I should start out by maybe talking about a little bit of history on global budgets and maybe getting to Senator Hardy's point on what we're able to do without legislation. So as Senator Lyons and Senator Cummings remember, we actually had a hospital in the state of Vermont that was willing to be the guinea pig for global budgets. And Senator Hooker, you should know that hospital was Rutland. And I think it was approximately 7 years ago. It could have been longer. Time flies, but it was moving through the Senate to set up RRMC as a pilot project. And I only bring this up because it'll give you some of the things that will be roadblocks that will have to be overcome if we were to scale this on a larger model and take it statewide. One of the first roadblocks was that there was disagreement on really how expansive a global budget should be. And in the perfect world, many people would argue that it should include the hospital, all forms of healthcare, the DAs, the VNAs, et cetera. And I would just say that if you try to pull that off, I think you're doomed for failure because it's asking to change too much too quickly. And so at the end of the day, even though there was this great debate about whether it should just be a global budget for the pilot hospital or should include a number of organizations, what finally killed it was the fact that the state of Vermont themselves, the Medicaid department, DEVA, could not put it in place. So it never moved forward. And then fast forward, we moved to an agreement with the federal government, the all-payer model agreement, and that's what we're operating under today. And for this type of global budget approach to be successful, it's going to take similar agreements because we would want to have all the payers involved in a global budget process. And it's something that, as Senator Lyons knows, I've always liked the concept of a global budget. I think it solves so many of the problems. So for example, preventive and avoidable utilization. If your organization is given X amount of dollars and you have to deliver certain deliverables, you're going to be having those discussions about, do we really need to be doing this? And is this proper protocols for care? And, one of the organizations that we looked at years ago in the Senate as kind of a role model for setting in place protocols for care was Intermountain Health out west. And, that's a big piece of this is I think it would solve a lot of the existing problems. Right now, you're rewarded if you're doing, the EKG and all these other tests that are necessary in many situations, but not in all. And so that would solve a lot of that. So that's just a little bit of history and some of the roadblocks that you might see if it proceeds. As far as Senator Hardy's question on what can the board do already, we're already taking steps on some things. So for example, regulatory alignment, using our existing budget, we have a contract with Michael Bailett, who has been working on exactly that. And so that is proceeding. We also have an RFP that's out there now. Again, it's within our existing budget that is looking for a contractor to relook at the regulatory process and how we regulate hospitals. Under a global budget model, one of the things that you would need to see is a shift away from the current regulation, which is focused on net patient revenue and fixed prospective payments and really charges, to one that's more guaranteeing that each of the entities that's receiving these global payments is delivering on the quality and the access to care. And so, and again, that's what we can do inside our budget. I can tell you that most of our reports do have summaries, and this has been an ongoing discussion at the boards ever since the first day I walked in. And I've tried to explain that what we really need is a quick summary that's always in the same place, that I use the 6th to 8th grade level and is understandable by Vermonters. And there's always some hesitation by people who have masters in health policy about doing that in the way that I would like them to do it, because then they feel like they're making themselves look stupid as they're putting out that report. But I think it's necessary, and I think that we could do a better job of standardizing some of the summaries so that they're much easier to access by Vermonters calling in, because I hear that from a lot of Vermonters who try to follow what we're doing. And, with all the acronyms and everything that's used in the healthcare world, it's difficult for somebody that has never spent any time in the healthcare field to really fully understand the full conversation. So,
Can I make a suggestion? You should get an intern, a high school intern, and have them read all of your reports. I mean this seriously. Like the 2 reports that I've written for the legislature, I've had my kids read, who are teenagers. And if they don't understand them, then I know that nobody's going to understand them. And it makes me check for the lingo, whether it's about carbon sequestration in forests or education financing, that it's something that at least a relatively well-read Vermonter could read, but is not too complicated. Because I read some of the things that come out of, just some of the reports that we get in this committee, and I don't understand them. So how are regular, quote unquote, regular Vermonters supposed to understand them? So get an intern, high school intern, and have them read all of your reports and ask them if they understand them.
Well
There you go.
taken.
That's less expensive
It's
than,
cheap.
yeah,
Yeah.
very cheap. I have my daughter do the same thing.
Yeah, it's
It
really
works.
helpful and it's good experience for the kids. I can get you some interns if you want, Mr. Mullen.
It would be helpful.
It's
Just as an aside, I instructed the person who was in charge of our communications when I first came to the board on what I wanted in that, and he promptly found a job someplace else.
Oh, so
I'll take
listen,
your
I
comments,
do have a question.
fine.
I do have a question. I know it costs time and money to get some of these summaries out. And I know that right now you're looking for, you're having some work done on alignment, for example, which has been a significant concern to us, in particular, for me, for many years. And so now you're getting this work done. But there's no obligation on your part to share. I don't think that your consultant is part of our legislative request. So there's no obligation for you to get the one pager back to us. So how can we be reassured that we will get some of these simple summaries that even we can understand?
So what I'm proposing, Senator, is that our staff does a couple of summaries, sends them to you, and sees if that is exactly what you want, get your feedback, so that we're not devoting a lot of resources to rewriting, every single report and then find out that we're not
Yeah.
delivering what you want. So if you would agree to provide that feedback to us, it would be helpful, and we could get those to you within a couple of weeks, just a couple of summaries. And
That's a good idea. Let's try that. And I know that I've got a team here who will help with that analysis. Senator Cummings, you have a question? You're still muted, Senator.
I like bullets. This is the finding A, B, C, D. Very short kind of outline. And then if I find something I want to go into, I can ask for a paragraph.
Okay,
I think it can be presented that way as long as there are links to more information that
Yeah.
somebody can click
Yeah.
on. And I don't disagree with what you're asking for, Senator Cummings. So,
You've been here and read them.
yes.
Senator Hardy, just go ahead. Go ahead.
Sorry, I didn't want to, Kevin, were you done with everything you wanted to say? I have a couple questions for you, but I didn't.
Oh, no, I hadn't even gotten into walking through each of the 8 recommendations, but go ahead.
Seriously, are you being sarcastic or do you really have 8?
No, he's serious.
Okay.
No, there were 8 recommendations that Donna
Yeah.
presented. and I thought you wanted our
Her
feedback.
recommendation. I thought you had 8 additional recommendations and I was like,
No,
oh
no,
God, please no.
no.
I do have a question of clarification and then I'll wait for my other question. You mentioned that you're working on regulatory alignment already. Could you define that specifically? What regulations are you trying to align with what?
Rate review and hospital budgets and ACO regulation are the 3 primary things that we're trying to bring into alignment. And the problem is, in the world that we're living in, I think ultimately most people would agree that we should probably get to a total cost of care measurement, but even that has inherent problems. So do you just use the same total cost of care for each health service area when one health service area may have much better demographics as far as age and non-smokers, obesity, better economic demographics, as composed to another health service area that has just the opposite in those demographics? Do you treat them with the same dollar amount when obviously there's a lot more health related issues in the one that has the worst demographics? So even that's not as easy as it seems, just moving to total cost of care on a per capita basis. But it's something that you could, if you had the right consultants working on it, you could create some weights and figure that out.
I was just about to say patient waiting. I'm
But
kind
no,
of
that's-
on
Bad
that. So
word.
if you want to talk about it?
So that we'll let the medical providers do that. I'm not interested in doing that. All right, Kevin Mullen, Chair Mullen, why don't you walk through the recommendations, and we've been through them once with Donna Kinzer, but
So
then
I could go pretty
I think-
quickly.
I think prioritizing for us is helpful. We've already, she's prioritized 5, 1, and 7 for us, but you may have a different perspective.
Well, I would agree that 5 would be my number 1 priority.
Okay,
But let me walk through them, and then we can come back to that. Number 1 was about a third party to perform per capita analysis, and
Yeah.
we agree with that. This is going to cost dollars, though.
Mhm.
Best guess, $500,000 to $750,000 to do this. So there's no disagreement there. The second recommendation about synthesizing, we already talked about that. And again, we'll run a couple of those by you, get your feedback, make sure we're doing what it is that you really want, and then we'll move on from there. Number 3, cost containment strategies for drug costs. And this has been problematic forever.
Yep.
Senator Cummings talked about Neela RX and other things that the state of Vermont has been involved with in the past. And we don't have a lot of regulatory authority over doing this. One thing that we have done is we created a technical advisory group last year to work on these issues, and it's really broken up into 2 subgroups, of which we would love to have you invite members of the subgroups in to brief you on what they think are some possible paths forward.
We'll
So-
do that. I was actually in contact with you folks about that. So, and we have a bill, I think, that might lend itself to that information and testimony.
And as was said earlier, it really hasn't been a prime focus of our ACO because when the all-payer model was negotiated, those costs were put outside of the targets that were in there. So a lot more attention could be paid to it. But let me just say that a lot of things that would really help are going to have to be done on the federal level. And we've been talking about this for
Right.
ever. And we don't seem to make the progress that is necessary. But number 4, again, we're working on this, and we would love to be able to eliminate regulatory structures, and in many ways, global budgets would allow for some elimination and some simplification, but you've got to get to that point. And one of the problems with where we're at today is we really have our feet in 2 canoes. And when you don't have the majority of care being paid for with fixed prospective payments, you still need to be looking at the fee-for-service world for regulation in today's world. So it's something that's a goal, and I hope we get there. 5 is I think is the most important recommendation from Donna. And let me be clear, though, that in order for this to be pulled off, there's going to have to be resources. And I don't want anybody falling out of their chair, but we're probably talking about at least $2 to $5 million for number 5 that will be necessary. And one of the things that's going to have to occur is there's going to have to be meaningful conversations at the local levels, and there's going to have to be facilitators, preferably, I would hope a medical doctor to be talking to the doctors in local areas about trying to transform the system. And so it's going to take time. And one of the things that I would hope is that whoever is facilitating the process is doing it in a way that everybody fully understands what they are committing to. One of the things that I continually hear on the all-payer model is that some of our leaders in healthcare believe they were misled, and I don't know if they were misled or if they were hearing what they wanted to hear, but many of some very smart people in the state of Vermont believe that when they were fully behind the all-payer model, that what they were getting into is a system where government payers were going to grow at the same rate of reimbursement as commercial payers. They believe that there was going to be hundreds of millions of dollars for delivery system reform. And so they feel like they were sold a bill of goods that wasn't really there to be sold. So this conversation has to be real, and it has to, not exaggerate what's going to happen with a transformation to global budgets. So again, we believe strongly that this is the most important recommendation, and this is something that I think would be the focus of a next agreement with our federal partners. That's why we were supportive of trying to do just a 1-year extension for the existing all-payer model agreement, because it allows us to have the time, and it really allows our federal partners to have the time to try to get us to a point where we can have an agreement that makes sense and moves us in a new direction. And there's been a lot of great work done in Pennsylvania. You may want to hear some testimony from Pennsylvania. You're already hearing some testimony from Maryland, and we've been trying to copy Maryland for years. So Donna Kinzer was on the front lines of that work, and so that's why I really think you had a great choice in who you pick for your consultant. Number 6, the health expenditure growth targets. This is something that, again, we agree with. It's something that also comes fraught with difficulties. So, for example, if you had a hard target in place for next year's hospital budgets, would there be a drop in access to care? Because it's no secret that workforce issues are going to have to be paid for. And I don't see us being under a CPI target for next year unless something changes very drastically overnight. I think we may be right back to a higher growth target, which is where we were at before the creation of the Green Mountain Care Board, where growth rates were 8% a year. And we don't want to see that happen, but I think that a 1 or 2 year blip is quite possible given what we're seeing today. Let's see, 7 on data model options, and it does require the statewide discussion, and it really needs working collaboratively with the next person you're going to hear from, Ina Backus, and making sure that it's done right. And when it comes to data, I would recommend that you, it's another recommendation for people that you might want to hear from, but Donna referenced the health expenditure analysis report, and Lori Perry has been a longtime state employee who's been the prime driver of that report for a number of years. She retires this year, and I think it would be great for you to hear from her. I know she's testified in the past in the House on the health expenditure analysis, but I'm not sure, has she been into the Senate? Senator Lyons?
Not recently. I think not since the pandemic. So yeah, it would be good to get her back in.
So she'd be very good. And also at the same time, during the same presentation, it would be great for you to have in Sarah Lindberg, who is the director of our data and analysis team. And if anybody understands what data is available and what could be done to improve it, Sarah's the person. So those would be two really great resources that are available to you at any time. So
What would be helpful as you're talking, I know you don't have any written testimony on our webpage, but to have this in writing, some bullets.
what I'm
some
thinking
bullets.
about doing for you, if this makes sense to you, Donna put it into an Excel format with the 8 different recommendations. And what I could do is send you my comments in an Excel sheet that basically has the 8 recommendations going down the first column, and then our comments
Perfect.
to those. If
Yeah,
that
no, that'd be
works for
great.
you.
And then,
Okay.
and then also do include reference to Lori and Sarah, because that will have that, and we can, Aaron can invite them in as we go forward.
Okay. So that goes to number 8, and about the authority and processes, the board structure, sufficient protection for non-affiliated providers. And I would think
Mm,
if you make the decision to be committed to recommendation number 5, which is global budgets,
Won't need that one.
that may solve a lot of this, and it may not be as necessary. I can tell you that there's a lot of state resources spent on regulation and oversight of the Accountable Care Organization already. And sometimes I wonder if we're getting a return for that investment. And I think there would be natural pressures under a global budget system for if the ACO were to partner with the local HSAs that were receiving the global payments to really make sure that what you're looking for in 8 occurred anyways. So I guess that would be all I would say on number 8. So again, for priorities, I would say 5 is number 1. Probably 1 would be number 2. 3 is always a priority. I'm not sure that we're ever really going to satisfy that priority as a state, but we can't give up trying. I know that one creative solution that nobody seems to buy into, I was intrigued by it, but nobody else seems to be buying into it. So I must be wrong on this one. But Senator Hooker, pharmacy director from Rutland, Jeff Hochberg, had proposed that we do something similar to what we do for liquor and have
Right.
one state wholesaler for prescription drugs. And
Yeah, that was a super proposal. And we haven't gone back to it.
I think it's
Maybe
part
we
of a
should.
bill that we have. I think we might see it on a PBM bill that we're looking at.
Are you, Senator Hooker, do you know if that is included in the House PBM
is.
bill, or is that, yeah, okay, I thought so. All right, good.
so again, on that one, I would definitely advise that you bring in some of the people that have been serving on our technical advisory group and hear their recommendations. And they do have some recommendations on PBM and things like that. So it would be good to hear from them. So again, I would put that as a priority, but I'm not sure, even though it's one of our highest cost drivers, if we're truly going to put a dent into that. And and then if I had to go to number 4, I would say number 7 would be 4. And then they start to all kind of get to be equal weights after that.
Returns diminish.
Yeah. But
Yeah.
again, number 5 is really where the
Okay,
biggest focus should be, I think. But again, I want to repeat this so that nobody says I wasn't clear, that it's going to take resources, probably between $2 and $5 million. And the sooner those resources were available to get going, the better off everybody would be.
okay. This is helpful, and actually your list resonates with Donna Kinzer's, perhaps with the exception of the prescription drug piece, but that's not a big deal as far as I can tell. We're always interested in regulating prescription drugs in a way that will keep the costs down and improve quality. I do have one question, and then I know others are going to ask questions as well. On you were mentioning the unfulfilled promise of equitable reimbursement and for folks under the global budgeting and the ACO, specifically related to the ACO. But it does seem to me that the equitable reimbursement piece is very important. And then if we're considering global budgets and fixed perspective payments for patients, has the Green Mountain Care Board thought at all about any equilibration between what happens at the FQHCs and other providers outside of those FQHCs? Because those payments are higher and they are, PPS. So
Yeah, the FQHC model is a great model, but the only reason why it's such a great model is because there's all these federal dollars that go along with it. And so we don't have any regulatory authority whatsoever over the FQHCs. And so it's not a world that we really play in whatsoever.
So then the question is, and I guess this is more of an Ina question, is there a way that we could build our system in a negotiated agreement with the federal government to be more equivalent with the FQHC system, so to speak? Yeah, I'm asking that now. Maybe Ina is listening. She'll reply to it, but you don't have to
Sure she
reply right
is.
now.
I'm sure
She's there.
I'm sure she's listening.
Okay. All right, before we go there, questions for Chair Kevin Mullen. Yes, Senator Hardy.
So Kevin, I appreciate the comments you made about moving the challenges of moving to number 5. I mean, in addition to the $2 to $5 million, which right now feels like is not so much money, but certainly really is. The necessity of local conversations and the need to not exaggerate the goals or the outcomes of this, I think, is really important, because that sort of leads into the trust question. Your comment about how some people feel like they were sold a bill of goods that didn't materialize with the all-payer model. And I guess with number 8, I'm not sure that I understand how Donna's recommendations in number 8 would necessarily help improve trust in the ACO. You heard my comments earlier. There's just, and you know this, there's so much distrust out there with the ACO. It hasn't done what everyone claimed it was going to do. The structure is really problematic. I know that you have the ability to regulate it more, but from the grassroots doesn't seem like that's happening. And it seems like it's just a distraction from getting the other more important work done at this time. So it just seems like for number 8, we need to do something to build more trust in the ACO, or to get rid of it and change it and do something different, while also continuing along the path of all payer model and global budgets, et cetera, et cetera. But right now it's a distraction from getting anything done.
And believe me, I couldn't agree with you more, because that distraction is so frustrating, because it's impeding progress that we could be making on healthcare reform. And let me be clear, though, the ACO has done some good things, and they don't always get credit for those either. And I think sometimes there's almost too much discussion about the big bad boogeyman being UVM, and I think that hurts them. So I think that global budgets could work with or without the ACO. I think there could be a role for them that would be very helpful. But the reason why I think that global budgets would solve the problem, because if they weren't delivering the type of care coordination and analytics that were necessary to provide the quality care at a reasonable price, then the local health service area would no longer contract with them to do that work. So I think that could happen outside of the regulatory world, just in the natural world of local hospitals making decisions that's in the best interests of their community. So that's the point I was trying to make there. I think that, and again, I hear very positive things from people across the country about what has been done by our ACO. So I don't think that I want to join the camp that believes that they're the total villain, but that's also one of the reasons why we required them in this year's process to benchmark against other ACOs across the country, so that we can see what they're doing right and what they're not getting right, and gives them the information so they know where they can improve. And I do think that there's some merit to the arguments against the affiliation, but I think the structure that's in place with the board of managers does alleviate a lot of that. And I don't want you to walk away from this conversation thinking I'm defending them. I'm just saying I don't think they're the villains that everybody portrays them to be.
And that may be the case, but they are a distraction from getting other work done, because there's so much distrust. So how do we get rid of that distraction? And without just, we can all say it, although I'm not sure I completely agree, but I think that we need to really think hard about how do we change that model, that structure, that face of the right now they are the face of healthcare reform, not you, not Ina, not your groups. They are, and people don't understand it, and therefore they become the boogeyman. And so we have to get away from that, and in order to get to the important work. So how do we do that? And it's not just about saying we're going to benchmark you against other states. There's got to be a change in the structure so people trust it more.
Well, I'm not sure that we at the Green Mountain Care Board would have the authority to require them to change that structure. So that may be a discussion for the legislature to have, but I think it's one that would require a lot of your time. And you really would have to walk carefully as you were, trying to figure out what that structure should be.
Alternatively, we can continue to work on some of the recommendations that we're seeing that will very much inform healthcare changes. And so looking at the recommendations that we have before us, number 5 is a giant step forward, and it would allow for community engagement, local provider community engagement. And as we're talking, I'm thinking of possible legislative recommendations that would carry that number 5 forward. And that could change the landscape and change the discussion to one that is more productive. Not that we leave behind the concerns that Senator Hardy has expressed, because I think there are very real concerns out there, but that we continue to take steps forward that ameliorate the concerns and move us in a direction that we have wanted to go for a long time. So it's an
And just
interesting
not to
mix.
state the obvious though, but one of the problems that is going to be when can we have those meaningful community discussions, and it's not in the middle of the Omicron outbreak. And
Do you know
I keep
what?
liking to think that this is going to be over soon, and it doesn't.
Oh.
So
every time we get a step forward on Omicron, it's 3 steps backwards. But you're absolutely right that we can only do what we can do. We can't control that terrible virus and its ability to change form. We've already heard it's changing form again. I don't know what it's going to do, but so yes, we won't go there right now. It's difficult, but we do need those community discussions, no question. Okay, any further questions for Kevin Mullen? This has been very helpful, and I do want to thank you. I do want to thank the board also for educating me a little bit a couple of years ago, pre-pandemic, as we started to get into the global budgeting discussion and meeting with folks in different states. And perhaps we will bring in Pennsylvania as needed, or go back and have Donna come in with some more Maryland, perhaps Massachusetts information. I know one of our consultants for the task force has a great deal of information about Massachusetts. So we do have people available to help us looking at that number 5, which is a pretty key, sounds like a key step forward. So thank you.
thank you.
All right. Ina, welcome. It's a pleasure to see you here. I don't think you've been in our committee this year as yet. So why don't you introduce yourself for the record, and then you've heard how we're going through the testimony, and maybe give us some perspective on the recommendations that we have.
Thank you. Good morning. My name is Ina Backus. I'm the Director of Healthcare Reform at the Agency of Human Services. Thank you for having me this morning. I echo Chair Mullen's praise for Donna Kinzer's report and recommendations, and the process that she engaged in to develop the recommendations for the Health Reform Oversight Committee. In particular, the timing of this information is very helpful, as Chair Mullen mentioned, particularly as we consider our work on a longer term renewal of a potential all-payer model in the state. My remarks and feedback are really going to focus also on those odd numbers that have been coming up throughout the discussion. So I'll focus on recommendation numbers 1, 5, and 7. I think with respect to recommendation number 1, that I was one of those staff people that came to Chair Mullen when he was interested in perhaps being very clear about how Vermont was performing in terms of cost growth. And I may have said to him, well, the way we're looking at things in Vermont are different than the way our other states are looking at. And so it's not an apples to apples comparison. And we're going to have to explain why we're different. And explaining why you're different and why things are not apples to apples is difficult to do. And it often makes a harder story to follow. So when it comes to recommendation number 1, I fully agree that if we can measure comparably with other states and have a benchmarking process using, again, comparable information, that is going to be an advantage to us, not only in understanding our performance, but in communicating about our performance, if we can simplify in that manner. So that that's recommendation 1A. And 1B is also of interest because it is so critical that we do understand patterns of avoidable utilization and low value care and how Vermont is performing relative to others in this arena. And this is certainly one of those aspects that we hoped the all-payer model would be attentive to. And I think performance in this area, as we highlighted in our implementation improvement plan, can and must improve. With respect to recommendation number 5, and as I suggested, the very nice timing of this report and information with our full attention turning to a longer term renewal for the all-payer model agreement. We absolutely need to consider and explore recommendation number 5 to look at fixed payment models for hospitals within an all-payer model context, both in or with an ACO overlay and without an ACO overlay. This needs to be on the table as we look to, as I said, a future longer term all-payer model agreement. We are very committed to moving away from fee-for-service and have talked a lot about that with this committee and others. And a key aspect of our model agreement is to continue to shift payment in a way that is predictable and that is focused on population health. And the framework here is certainly a potential to explore for more completely transitioning payment from fee-for-service to fixed payments. We saw the benefit of this during the pandemic, particularly with the fixed payments that were flowing to providers under the Medicaid model. We've pointed repeatedly that this needs to be an area of expansion across all payers, that all payers are participating in this fixed model. And again, that we need to certainly improve the predictability of payments in our system across all payers. So again, this recommendation is welcome. We would like to explore it fully in all aspects and permutations as we work through our process to understand our opportunities for a longer term all-payer model agreement. The recommendation number 7, I agree also with Chair Mullen that this is an area for collaboration. We do, as you know, have the health information exchange in the state of Vermont, and our health information exchange steering committee has some very explicit goals to improve and to diversify the information in the health information exchange so that it can be applicable for a variety of health reform purposes, and certainly also to be incorporating where we can additional data types like social determinants of health data, claims data in the health information exchange, married with the clinical data, and available for health system transformation.
Are you ready for questions?
Yes.
Good. Okay. I couldn't tell whether you had gotten to your endpoint. I do have a couple questions, and they get that whether or not that you can fully answer them. I'll start with the last one first, because you just finished with a health information exchange and other data to add in. I know that the FQHCs have been working very hard, including the social determinants of health within their primary care work, and whether or not the blueprint is also, does the blueprint also have that included? And we probably need to hear from blueprint folks for a couple of different reasons, but maybe asking them this. And then I know that primary care practices do include social determinants in their patient work. So as you're talking about including that in the database, has that been looked at all through your office or others?
Yes, it has. And I certainly would welcome a deeper dive discussion in this area with others on my team. But I can say confidently that we're really looking at the social determinants of health data is available in a variety of formats. And there's health, just as you're indicating, social determinants of health data, which is already within the clinical record. And then there are other social determinants of health data that may be outside of the clinical record, perhaps data types at the Agency of Human Services, for instance, relative to non-clinical social determinants, or that would not be found in the clinical record. So we're looking at utilizing those social determinants of health data already existing and determining whether we can integrate social determinants of health data types that are not currently in the clinical record.
Right, that begins to step out into other social service areas, and it does get complicated. I can see that, but having it at least embedded in the clinical practice is a help. So, okay, that I have a couple other questions, really more probably related to number 5, and that is the question that I asked earlier regarding the FQHC payment system, and if there's a way to, as we're looking at global payment shifts and changes and looking at our all payer model, has there been any thought to moving our payment system to something, at least in primary care, more consistent with what the FQHCs are doing?
That's a good question. I think it's a particularly good question in the context of certainly how Medicare could participate in a future model iteration. To answer your question straight, no, we have not looked at specifically, a matching primary care model that is mirroring the FQHC model, but that is certainly an area of exploration.
So that's helpful. And, it does become a Medicare question if we're looking at our all payer system, and then how to proceed with that. It does, for me, it responds to a lot of the concerns that we hear about inequitable reimbursement and increasing equity within the system that can only help access and affordability overall. But we also, no, it's complicated. We know it's complicated. The other question I have is, as we're looking at or thinking about here, our group, our committee, thinking about how can we get the local conversation going around number 5 and maybe some of the data and questions going considered at the local level. I know there must be some things going on now with our primary care folks. I think there is, but this is a process. I mean, it's a huge process to bring all this information to people simplistically, and clearly, so that there is, as Senator Hardy and others have said, that we can build trust with anything that is taken forward. So who's in charge? I mean, who would step forward to build the system, the facilitation process at the local level? No, so I'm not particularly interested in going out and doing that across the state, but who would do that across the state to ensure that the information is, and I'll just take a step backwards. I go back to the public engagement process that we had for renewable energy. And we had groups going around the state, and we ensured that we were gathering the information we needed and providing the information that was accurate. So have you given any thought to how that might happen at the local level? I mean, you may not have, and that's okay, but it's something we may be thinking about in our committee.
I want to step back and think about number 5 as it's a very valuable option for us to explore, but may be one of a number of options in considering certainly how, let's just be narrow in our discussion, how Medicare might continue on in a Vermont specific payment reform model. And so in answering your question, I wouldn't say that, I necessarily focus just on how we would have local conversations about option 5 specifically, but having local conversations and being sure to have an opportunity for potentially a wider number of concepts to be shared. But I think that there is also some very important key constituent engagement that needs to happen in addition to that, and to inform concepts that would then be brought to a wider audience. I think those key constituent conversations also do have to be at the local level.
When you say key constituents in this context, who are you thinking about?
Well, certainly provider types across the continuum that might be newly, have a new revenue model. For instance, taking number 5 as an example, would certainly be a key constituency, along with healthcare payers, also key constituency in participating in a potential new revenue model. But they are not the sole audience, but there needs to be an opportunity for some input to the concepts, and then an opportunity for the concepts to be shared even more widely. Input to the concepts at the local level.
Got it. Okay. Okay. Go ahead, Senator Hardy.
Thanks. And thanks, Ina. Just to carry on this conversation about key constituencies, and I'll just repeat what I kind of always say when we have these conversations, is that it really feels like we're always forgetting that patients are and I know a lot of people call them consumers. I hate that term in this context, but people, real people, are at the sort of root of our healthcare system. And I would want to make sure that those are included. And I think one of the reasons that we get into these conversations about whether or not healthcare reform is working is because we haven't done a good enough job of including real people and the end users of our system in those reform conversations. And I'm wondering, and I don't know if you would know, or Kevin or Donna, whether there's data about if we did move to something like a global budget system or whatever, how it impacts the end users of the system. Like, would they see a difference? Would people see a difference when I go to have a healthcare appointment or take one of my kids and then pay for it and get the results of it and all that? Would I see a difference? There's certainly some things that we did last session that I actually saw a difference in, and not always necessarily positively, when I was using the healthcare system. So I'm wondering, if there's data. So many of these recommendations are about data. So I would like to see, are there end user data that could be valuable in this process that you know of?
This is Donna. Did you want me to say anything?
Sure.
Dina, or do you want to?
Either one of you, welcome to respond.
I'd love it for you to jump in, Donna.
Okay. Well, I will tell you, when we implemented the global payment model in Maryland, we had the leaders of consumer advocacy groups involved from day one. And they sat on all of the work groups, and it was actually wonderful because it stopped a lot of the rhetoric between payers and providers that can happen in some of those meetings. When the consumer was in the room, the whole tenor of things changed. And there was a lot of focus on how things would impact the consumer. One of the consumer advocates did video conferences around this, or did video consumer group work around the state to try to understand what consumers would need to understand. And the consumer groups actually got involved in educating consumers around the state and health departments, and they went around the state and helped with the education of how the system was going to help the consumers moving forward. And so I think that was a very productive process, and they were always at the table for input to the regulators and throughout the process. We also had a very good complaint response system with the doctors in the state. The medical society had my phone number. If there was a complaint, honestly, they called me, and we cracked down on anything fast that there wasn't a second delay to responding to the doctor. So that there was a very informal system that worked well. And you all have a kind of the size of a state where an informal system could work well too on that type of thing. But so really having the doctors have availability to have their complaints, and this involvement of consumer advocate. You have a very good consumer advocacy group in the state that is involved in the regulatory process. So I think the venue is there and can be brought to more fruition as you try to go through the implementation of the new system. What I heard from some of the patients is what they saw. They saw a whole different response from the hospitals as they were coming through the hospital. When they were getting ready to leave, instead of just being sent home, there was attention being paid to, do you have food at home? Do you have anybody living in the house with you? Lots of work on medication reconciliation to avoid patient and family confusion, sending people into the house to make sure there weren't conflicting medications in the cabinet that were going to cause the patient to come back to the hospital. So I heard those stories directly from the patients that was working. And I actually experienced them in my own family when my husband was in the hospital. I experienced the same kind of things on the, in the discharge process. So there was a lot more attention to making sure somebody had a way to get, do you need transportation to the doctor's office? Do you need this? Do you need that? All of that was taking place and I saw that firsthand, as well as hearing it secondhand from the consumers and the consumer groups. And so that's my personal experience with the consumers.
Can I,
Thank you. Well,
Yeah,
can I just follow up?
okay, you follow up, then I'll follow up. Go
Okay.
ahead.
Well, Donna, thank you. That's really helpful. I think maybe if you're willing to share your model for grassroots kind of patient integration and advocacy and would be helpful. I am right now texting with our patient advocate who would be very interested in participating and leading something like that. Some of what you just said you saw happening already does happen in Vermont and probably elsewhere. Just to be clear, there are certainly healthcare providers who ask those questions and do home visits and do all those things too. But I think that your point about having patients or consumers or whatever you want to call real people in the room to prevent some of the sort of negative back and forth between providers and payers is really, it's kind of like when the kids are in the room, the parents are going to be less likely to bicker in a way that's unfortunate. Hopefully, that doesn't always happen. But I think it's really important that whatever we build, we do include them from the very beginning intentionally. And I just want to keep reminding people that. Ina, I do have another question for you.
Can I follow up on this thread
go ahead.
and then go ahead? Because as we've been talking about number 5, it's very clear that the information needs to be carried to the local level. Maryland has done this in some way. And I was going to ask the same question, that if you don't mind, link us to the process that Maryland used in communicating, or others, if there are other states that have done that, if you can do that, and we can also certainly sort it out some way. But then the question also remains, and I got the text as well from our advocate, our patient advocate, healthcare advocate. There are a number of people who would be very, very willing to support the process and going around the state. But we need to have some direction for that. I think we're going to have to ponder on that in our committee to put something together. And then having the administration, the Green Mountain Care Board, the healthcare advocate, someone's going to have to be in charge, or is it a disinterested, objective consultant who's in charge? So those are some of the questions that I see you, Senator Cummings. Those are some of the questions that we're going to have to ask and ponder on as we look at how we might go forward on number 5. But there's a long way to get into that. So the question of how is critically important. Senator Cummings, did you have a question?
No, I was just losing the train of thought.
Oh,
We started out, my agenda's gone away. Number 5 is fixed global payment options for hospitals. And somehow we've gotten into a consumer advocate public outreach.
It's because
And
so why don't we let Donna Kinzer?
I'm losing I can see where there is a connection, but it isn't the prime issue for me.
Okay, that's fine. Does someone, Donna or Ina, do you want to respond to that? No.
The
It happened because
consumers
of my
are
question.
always, oh, sorry.
Yeah, no, go ahead, Donna.
Consumers are always, are may be concerned, or legislators may be concerned that something could be taken away instead of something being better. And so in order for the hospitals to succeed, what they have to do is work with primary care doctors to help them strengthen their work in the community to avoid people having to come to the hospital in the first place, because they're getting better preventive care and they're getting better access in the offices. And they also have to make sure that they're working to get the patients who do visit the hospital effectively back into the home or into social supports if they need social supports. So those things are very consumer, they're very consumer involved in having the consumers at the table explaining what's going on, and then also being demanding about what they want is helpful in the implementation and effectiveness process. So that's really the linkage back to the consumer, is that to make sure that the system is focused on improving outcomes and the quality, not the old style of just not doing things and denials, the old style of denials. That's not what we want. We actually want care improvements and care moving back into the office and better coordination. And so that's why we have to have the consumers at the table.
And
good
it's a
consumers
ways,
No, I-
down the road, Senator. I agree with you.
Yeah, I've got consumers at the table, but it started to sound like we were doing public consumer forums. And I wasn't sure how we got there.
We were just figuring out where we were going. Senator Hardy, you were in the middle of your questions. Go ahead.
Thank you. So I think one of the important things is the timeline. Right now, I think it would be extremely difficult to implement any kind of changes, especially given where our hospitals and healthcare providers are with COVID. And I just want to make sure that anybody who's listening doesn't think that we're going to start implementing this right now. Our hospitals really are in crisis right now and really need to recover from that crisis before we put them through anything else, including a whole public engagement campaign. So that reminds me of my question to you, Ina, was there's a whole bunch of kind of deadlines of renewals of various kinds coming up. Could you just remind us? I think there are maybe 3 big ones. Could you just remind us what they are and when they are?
I'll do my best. We are in the first month of the final year of the all-payer ACO model contract. It's 2022. It's the final year of the complete contract, and it's the last performance year. The contract began with performance year 0 being 2017. So we're at the beginning of performance year 5, the final performance year in the existing Vermont federal relationship. We have proposed to our federal partners a 1-year extension, and we are awaiting response from our federal partners about their receptivity to that proposal.
Okay.
We proposed that, I think, in part, as you just recognized, because of the circumstances that we are in with respect to the disruption caused by the global health pandemic and the necessity that there be some bridging time between where we are today and where we want to go for a longer term future. And so that's where we are. So I think I really only have that one deadline for you.
Aren't there some waiver deadlines too? Or did we pass those waiver deadlines?
Waiver's another thing.
I'm speaking only about our contract with the Centers for Medicare and Medicaid Innovation. That is the contract that facilitates Medicare to come to the table in Vermont and do Vermont health reform. We do have a companion, we have an 1115 Medicaid waiver the state of Vermont has. It's called the Global Commitment to Health, and the Global Commitment to Health waiver for our Medicaid program to operate, waiving certain federal requirements and to operate a Vermont program of Medicaid. That global commitment has, existed since 2005. So we're in another cycle where we are renewing that. That waiver currently does facilitate Medicaid's participation in an aligned multi-payer model. And we would look for that to continue in the renewal, which we are still negotiating. That 1115 waiver period did come to an end officially in December of 2021, but we have received a 6-month extension of our current agreement through June of 2022. And so we will be continuing to negotiate and hopefully come to terms, as soon as we possibly can.
And the first one, the all payer model ACO, that's the one that is connected to whether or not we continue with OneCare.
It's not connected. The all payer ACO model agreement, the agreement that we're currently in, provides for specifically the Green Mountain Care Board to offer what's called the Vermont Medicare ACO initiative. So
Okay.
the Green Mountain Care Board in this arrangement shapes what otherwise would be an off-the-shelf Medicare ACO program. And that's what really tailors it to the state of Vermont, is that. And so the agreement has the agreement speaks to no single ACO being a participant. It is the case that we have one ACO in the state of Vermont that has signed up and does participate, and that is OneCare.
Okay, so that could continue with a different ACO or some other, if one existed.
Yeah, I certainly, the agreement that we have, we've asked for a 1-year extension of that agreement. We've asked for that extension with some critical changes to move more towards fixed payments fixed payments for the ACO from Medicare, which moves more Medicare dollars into the fixed predictable range. So we have asked for some significant changes for the 1-year extension.
Could you provide a summary of what you asked for, or have you? To us? I mean, not right now. I mean, like written, just like bullet points, or a flow chart, like Senator Cummings asked for. I would just be curious, what are the parameters that you have asked for in the renewal?
Yep.
Yeah,
Absolutely.
great.
Absolutely. Yep.
Thank you. Okay, I think I'm done for now. Thanks, Senator Lyons.
Okay. Yeah, that's a good.
I'm sorry to jump in. I need to say that the renewal proposal really is a bridge to a longer term agreement and allows us the time to engage on these concepts and ideas, such as that raised by Donna Kinzer in her report to the legislature. It allows for us to explore those and other ideas that may emerge.
So why don't we do this as you're sending us that information? And I don't know when we'll get it on our agenda. We do want to keep moving forward on some of our bills, but it would be helpful to have you come in and just talk briefly about the bridge that's being put in place and what the thinking is about next steps. Can we do that at some point, Ina?
Yes.
Good, that'd be terrific, because I know there's a lot of interest in this, and it'll help us, I think, also with any work that we do on the recommendations that Donna has brought to us and any steps we take in our healthcare accessibility, affordability work legislation.
And
Senator
Madam
Hooker.
Chair, thank you. Thank you, Ina. Along with, what we would like to hear about what the recommendations were, or what the requests were for the extension, maybe a clarification of what happens if the extension isn't granted. So,
That is a great question. If the extension isn't granted, that means that Vermont would no longer have an agreement with the Centers for Medicare and Medicaid Innovation for Medicare to participate in health reform in the state on the Vermont terms. It doesn't mean that any ACO operating in the state couldn't participate in other Medicare ACO programs that are offered, or participate, in a commercial ACO contract, for instance. It doesn't, our all-payer model agreement doesn't authorize ACO activity in the state. It really authorizes the state to shape an ACO program to be aligned across payer types. So does that make sense?
I think, listen, Senator Hooker, does that, yeah, go
yeah,
ahead.
that's fine. That's fine.
Okay, I'm thinking that we're getting into an area of conversation that I think is going to require some more time. And we've come to the end of a long meeting on the recommendations from Donna Kinzer, which has been extremely informative and helpful to us. But we're going to invite Ina back in. Does that work for you, Senator Hooker? You can dive more fully into your questions.
It will take time, believe me.
Yeah, and that's
to
okay.
understand all of this.
We understand. This goes beyond rocket science. It is complex. And as we say in our committee, it is more complicated than that. So Chair Mullen, you came on. Did you want to add?
As I heard that you're wrapping up, I was just going to thank you for the opportunity to be here today. It's a great conversation, and hopefully we can move forward and make some progress.
Well, I can't tell you how much I've appreciated the conversation today. I think everyone has benefited from it in different ways. We're all at different places in our understanding and our need for information. So this has been a very refreshing meeting. We will continue with this work, and I think each one of you will be invited back in at one point or another, so to help inform our legislation. So thank you so much. And Donna, I don't see you, but I know you're there. And I just want to say thank you again for all your work.
Thank you for the opportunity to serve you.
Terrific. And I hope that we'll see you again in the committee. I know we're going to see Ina and Kevin again, and Senator Cummings.
I was just saying, we've talked about the public distrust, and we hear from the ACO, we hear from Green Mountain Care. There is an organized group, and it might be, and we have the auditor's office. And as we do this, it might be helpful to give everybody their
Fair share.
Their share, so that we know what the concerns are.
We will do that. What we don't want to do is, as I think, as we have said, I think it was Senator Hardy who might have said it, or others, that we don't want to get sidetracked. We want to keep moving forward. So it's a delicate balance and, but we will hear from folks. Um,
Well,
And
Madam
we'll
Chair, since
try
you
to make-
mentioned my name, I had also requested that we hear from the
yes,
auditor.
and
from
I was
the
going to
group.
honor that
So
request.
I don't think that's a
Senator.
sidetrack. I think that's really important that we do that.
No, I don't. What I mean by sidetrack is we could go down the road of exploring all the criticisms rather than taking steps forward to build the trust that is needed or to change the process. So it's a delicate balance and it is complicated. So we'll continue to look at this. But that wasn't the first thing that I put on the agenda because I thought today would be more useful than that. And but going forward, as Senator Cummings and Senator Hardy continues to ask, we will bring folks in. So thank you all. Aaron, we can go off